Good morning, everyone. We do have a quorum, I'm relieved to say. Obviously a very good night last night. It's my pleasant duty to introduce the first session of today's proceedings, and I'm welcoming Brad Francomb to the podium as the chair of that session. So Professor Brad Francomb, Conjoint Professor with Western Sydney University School of Medicine, was elected as the President of the AMA New South Wales in May 2016. Professor Francomb is an allergy specialist and immunologist at Campbelltown Hospital and also a member of the South Western Sydney Local Health District Board. Professor Francomb was an early appointment to the University's School of Medicine when it was first established in 2007, where he held the role of Clinical Dean for the school's clinical school based at Campbelltown Hospital. Welcome, Brad.
Thanks very much, Bev. And I'd like to pay my respects to the traditional owners of the land on which we meet today, to their elders past and present. So we've assembled a very highly qualified panel today to talk about an important topic. The AMA's first position statement on obesity was released in 2009, but our work in this space started long before then. Early on, preventing obesity in children was our predominant focus, but as more data and research evidence emerged, the true extent of the problem was increasingly apparent, and the AMA is focused on a range of issues, such as the health implications and the related increases in chronic disease, the impacts on the health system, not just the increase in demand, but the need for new, specialised and costly equipment needed to ensure safe and appropriate care, and the cost to the health system, to governments and to the broader community. The media has also been keen to know the AMA's position on things like the baby food diet, juice cleansers, Heart Foundation ticks on fast food, Pete Evans and paleo, the benefits of exercising on vibrating platforms, and whether saunas and steam baths are an appropriate tool for weight loss. So what is our position? Our position statement was updated in 2016 with expert input, in fact, from some of our panellists. It contains a broad range of calls for action. And while we don't have time to explore all 26 of these calls, the statement does cover aspects such as a major focus on preventing obesity in children and adolescents, creating healthy communities through a range of measures including town planning, urban development and transport infrastructure, and measures that promote physical activity and active transport. Targeted measures for high-risk or vulnerable groups, especially Aboriginal and Torres Strait Islander people and those from lower income groups, as well as community-based pilot programs and initiatives in local communities. Significantly higher taxes and therefore higher prices to be applied to products known to significantly contribute to obesity. And for healthy foods to be subsidised to ensure the prices remain low, particularly in remote areas. And opportunities to be extended for doctors to spend time with patients who are at risk of becoming overweight and to have ready sources of current information on interventions, counselling and local facilities that are able to support these efforts. There is now almost consensus amongst health groups that 3 measures must be included in any response to obesity. 1, a tax on sugary beverages. 2, restricting children's exposure to the marketing of unhealthy foods. And 3, a need to increase participation in physical activity. Despite recognising the need for action on obesity, both of the major political parties have made limited commitments. During the last federal election, we saw the ALP release a 5-point plan to prevent chronic disease, and this plan included commitments to a national physical activity strategy and a national nutrition framework. There was also funding for 50 healthy communities. These communities would be identified as those most at risk for chronic disease and would receive targeted support to match the needs. Examples of how the program would work include working with local food producers, distributors and vendors to make healthy options available in schools, and also working with local and state governments to increase opportunities for physical activity. An additional $5 million was also committed to the Stephanie Alexander Garden Foundation in order to establish healthy eating habits for life. The Coalition's commitments include encouraging and increasing physical activity participation among school children. There was the commitment for an additional $60 million to extend the Sporting Schools program, a program that provides funding to coordinate sporting activities, coaches and teachers to deliver sport before, during and after school. Despite the Prime Minister telling the National Press Club in February that a new focus on preventive health would give people the right tools and information to live active and healthy lives, the recent federal budget provided only piecemeal responses. The government committed $10 million to the Heart Foundation to establish the Prime Minister's Walk for Life challenge that is meant to see 300,000 Australians become new regular walkers. A further $5 million to develop education and training material for GPs to support Australians achieve healthy lifestyles through improvements in nutrition and physical activity. Given the extent of the problem and its long-term implications for our health system and also the Australian economy, it is surprising that our key decision-makers continue to balk at serious engagement with this issue. A line we use in the AMA often is that obesity is rivalling and perhaps now outranking tobacco smoking as the greatest contributor to preventable disease. Australia has made significant gains in tobacco control. We've reduced the rates of smoking significantly through the introduction of measures like plain packaging and increases in excise. However, when it comes to obesity, we can't seem to connect the dots. Lack of action means that Australia has the 5th most obese population in the OECD, and responses continue to preference personal responsibility when in reality we are all paying the price. So on to the sugar tax. One measure that appears to be politically unpalatable in tackling obesity is the proposal for the introduction of a sugar tax. While the Treasurer initially declined to comment on the proposal, the Deputy Prime Minister and Leader of the Nationals called the proposal bonkers mad and confirmed that the Nationals would never support the proposal. Following Barnaby Joyce's lead, Scott Morrison labelled it a well-intentioned suggestion, but noted that diet and the fight against obesity was a matter of personal responsibility. The spokesperson for the Shadow Treasurer, Chris Bowen, advised that Labor did not support the proposal either. This commentary was generated following the release of the Grattan Institute's report, A Sugary Drinks Tax, Recovering the Costs of Obesity. The report recommends a tax of 40 cents per 100 grams of sugar in soft drinks, sports and energy drinks that would add 80 cents to the cost of a 2-litre bottle. The measure was expected to raise about $520 million per year. We have the lead author of the report with us today, Professor Stephen Duckett from the Grattan Institute. Welcome, Professor Duckett. So, Professor Duckett, many sugar-growing districts are in marginal seats. Do you think there is any political will to introduce a sugar tax?
So I was quite pleased that Barnaby Joyce referred to our report as bonkers mad. I can't think of a better endorsement from that sort of person. So there is some claim that the next election is going to be won and lost in Queensland, and certainly the government and to some extent the opposition are concerned about the incursions of One Nation. So you've got to look at the politics of this. And there are a number of ways of looking at it. If you believe in rationality, especially economic rationality as I do, then you can look at the impact on those areas. And we do know that, yes, if a sugar tax works as it is predicted to work, there will be a reduction in Australian sugar sales. But that reduction is going to be marginal. A couple of % of Australian sugar production will be not sold in Australia. However, the sugar market is an international market, and Australian sugar production is relatively small relative to the national market, and so there is the potential to sell that same amount of sugar elsewhere, that is overseas. Now, we don't have any evidence about what the relative profitability of selling sugar in Australia is versus selling sugar overseas. The sugar prices, the profitability information is not available, the price information is. And so our estimate is there's going to be very limited impact on sugar employment. However, that's not to say that this could not be hyped up into a much, much bigger story and an attack on the sugar industry. Setting that, so I can understand the politics of it. I can understand why people representing sugar seats, such as the National Party, would be concerned about how a sugar tax would be presented, especially by One Nation. You put that into one basket, and then you put in the other basket that a place like Bundaberg has some of the highest levels of obesity in the country. And so you've got to think about what are those local members thinking about is the solution to the obesity in their very electorates. We are not looking to see either party make an announcement before the next election that they're going to go with a sugar tax. For the reasons that I've just outlined, the politics are actually difficult. However, I think a sugar tax is inevitable in Australia because of the broad sweep of what's happening across the world and also of the impact that it could potentially have. So sure, it's politically difficult, but if politicians were only expected to make politically easy decisions, you'd ask why we pay them any money at all.
So we know that a tax on sugary beverages could generate over $500 million per year in revenue, but is there any evidence that the measure would actually reduce consumption of sugary beverages and have a measurable impact on obesity rates?
So there's a couple of different answers to that. We think, what we're aiming to do, or we think that a tax on sugary beverages will not reduce markedly levels of obesity in this country. What we do hope, and what the evidence seems to suggest, is it might slow the growth in obesity. That is, the trend is upwards. We hope that a sugar tax, or we expect a sugar tax to change that trajectory. You're going to have to do a lot more than a sugar tax to turn the curve downwards. So we think there is the modelling is there. Certainly the evidence overseas is very, very positive. In the studies that have been done, Mexico, Berkeley, have shown that there is substitution from sugar-sweetened beverages to water, amongst other things. So there is evidence that the substitution occurs, but there's a number of links. There's the sugar tax. Then does it change behaviour in terms of consumption? Then does that consumption change into reductions in obesity? As I said, the evidence on the first bit is clear. Sugar tax changes consumption patterns. The next step, consumption patterns into obesity, is a little less clear. But as I said, we're aiming to flatten the growth, not change the trend.
So, Stephen, do you think a sugar tax should be implemented before other measures to address or reduce the rates of obesity? And if so, why?
Well, the reality is that other measures exist now, so it's not going to be before the other measures. If I go back to Bonkers Barnaby's comments, what he said was, "Oh, look, you should do more of the same." Well, you've all heard the quote allegedly attributed to Einstein that if you keep on doing the same thing, the definition of madness is you keep on doing the same thing and expect a different result. As an aside, I'd point out there's no evidence that Einstein ever said that, but setting that aside, the existing strategies are clearly associated with an upward trend in obesity. So you've got to do something different. The answer is you've got to do, at the moment, we've got essentially a lot of talk about individual responsibility. We've got some action about individual change, and I think Tony will talk about some of that GPs can do. We've got the work Jane is doing, which is sort of community and local level or individual level. We've got a number of community level interventions. We have very few structural level interventions to change, say, obesogenic environments or to try and shape activity. So my view is you've got to have interventions at multiple levels, and the missing level at the moment is that top level. So we've got to start intervening at the top level through tax changes and other things. Importantly, the tax change should be supplemented by better labelling so people know that this is a taxed drink, which means it's got a lot of sugar in it. So it's a combination of things that we should be doing, not just a tax and thinking the tax is going to fix everything.
Stephen, do you have an opinion as to what money raised from a tax should be spent on, and should it all be spent within health or specifically on obesity programs?
In our report, we left open where the money would go, partly because we structured the report to say this is how much obesity is costing the taxpayer now, so there's a legitimate argument for it to go to the bottom line. The hope was that this would make it a bit more palatable to the Liberals to put it into the bottom line, and so we didn't say where the money should go, and that was also partly because we hadn't done the evidence about what worked and what didn't. However, what I would say is every time a sugar tax has been introduced overseas, it's been hypothecated to obesity reduction programs, and particularly to obesity reduction programs in children.
Thank you. So I think it would be a good segue now to talk about the role of the food industry. Alongside the politicians, the food industry has been a vocal opponent of a tax on sugary beverages. When the Greens announced their sugar tax policy, the AFGC labelled it an attack on 40,000 regional jobs, saying that it would not improve the health of Australians. The Australian Food and Grocery Council also supported comments by the cane growers chairman, who said the sugar tax would have a massive negative reputational effect on cane farmers, that rather than be targeting a food product, we need to continue to focus on the totality of health and wellbeing. And Dr. Jeffrey Annison joins us today, who is currently the acting CEO of the Australian Food and Grocery Council, and I would like to thank him very much for being here. So, Jeff, I appreciate that certain parts of the food industry, namely soft drink, juice and confectionery producers, have concerns about the proposal for a sugar tax. Are these concerns shared by the food industry more broadly? And why don't you support a price signal that might encourage people to make healthier choices?
Oh, okay. Well, first of all, thank you very much for the opportunity to speak here. I guess the food industry is more concerned about the wider implications of a sugar tax on carbonated soft drinks, primarily because of the fact that we support evidence-based interventions. I think one of the concerns of the farmers is that if you impose a sugar tax, you're targeting a single nutrient, and not just the fact that it's a single nutrient, but it's a nutrient that's been demonised for the last 40 years in the media, and particularly in more recent times. And we've seen some really quite interesting stories in the debate, suggesting that sugar is the next tobacco. So I think the farmers have a legitimate concern about the fact that the sugar tax debate is in fact part of a smaller debate about the role of sugar in the diet. Now, the evidence is that sugar isn't particularly obesinogenic, or not uniquely obesinogenic. There was a very large study done in the UK that was published last year, 134,000 individuals, and sugar as a macronutrient was fourth on the list of the importance and contributing or the link to BMI in the UK, after, of course, carbohydrate, fat and protein. So it's not uniquely obesinogenic, and it certainly shouldn't be demonised as it has been demonised. With regard to the effect of a sugar tax, published last year in PLOS One, an article by Professor Leonard Veerman from the University of Queensland, a professor in public health, really advocating a sugar tax, but on 20% ad valorem tax onto carbonated soft drinks. Now, the effect of that in his model was that there would be a 16 kilojoule per day reduction in the energy intake of men, and only 9 kilojoules per day for women. This is against a backdrop of us requiring at least 8,700 kilojoules per day for a sedentary adult. So the impact on the energy intake of such a tax is low, and the reason for it is that overall carbonated soft drinks actually contribute very little energy to the diet. And that was in fact a conclusion from the Grattan Institute report. They were very careful not to suggest, and you've just heard Stephen reiterate that this would have a major public health impact. So the impact of a sugar tax in terms of the fight against obesity is likely to be negligible, but it could divert us from other more important activities. And of course then there's just the theory of taxation. Now clearly in the Henry Tax Review in Chapter 11, and some of you may recall that, they were specifically asked to look at taxes to change behaviour. And one of the issues they raised was substitution. If you increase the price of one component of the diet, what's unpredictable, and none of the models that have yet been produced have actually predicted this, is what happens to people in terms of substituting other foods. So the bottom line of this is that not only is it perhaps targeting the wrong, certainly the wrong nutrient in suggesting it's particularly obesogenic, certainly targeting the wrong group of foods, suggesting that if you tax sugar-sweetened beverages, it'll have an effect, and certainly in terms of just the taxation policy, uncertain about how it will affect other foods. Now, of course, we've already had to some extent a sugar tax in this country since the GST was introduced. The GST only goes on processed foods, and again, these tend to be the foods that tend to be higher in sugar. Well, they're not the fresh foods, so it excludes fresh fruits and vegetables and a number of other fresh products. So we're not having an effect. We haven't seen an effect from the GST. So I would say that the evidence is not strong that a sugar tax would have an impact on obesity. And in the absence of strong evidence, the Food and Grocery Council is not supportive of such a tax.
So in terms of your council's support for a continued focus on health and well-being, at what point would you concede that with well over half of Australian adults overweight or obese, that we need to take some action more decisively? So the cost of obesity is estimated at between $8 and $12 billion per annum. So at what point does the impact obesity is having on the health system and the broader community become the actual priority here?
Look, there's no doubt that the government ought to have obesity as a priority issue, and we certainly support calls for that, and we certainly support more expenditure to be done on preventive health. However, the McKinsey group produced a report, must be almost 2 years ago now, and they identified 71 different policy opportunities that governments around the world could take, recognising that obesity is an extremely difficult problem, and there's no single policy that's going to be, if you like, a panacea to the obesity debate. Not only in that, in 2009 we had a major undertaking by the federal government, which was the Obesity Task Force, looking at, amongst other things, we're looking at tobacco and alcohol, but also targeting obesity. They also concluded that there was no single factor or no group of factors that could be readily identified in terms of a policy response or indeed a regulatory response. So this is an extremely difficult problem. Notwithstanding that, the food industry has got a very strong track record, if you look back in time, of what it has been doing in order to help in the struggle against obesity. And I'll just mention one of them. As long ago as 2005, the food industry donated $1 million to the government. So the government kicked in $2 million. The food industry, through my organisation, kicked in $1 million to fund the Children's Physical Activity and Nutritional Survey. And the purpose of that was to try to get better data around childhood obesity in particular. Now, I could name a whole range of other initiatives that the food industry has contributed to, both at individual company level, but certainly at an industry level through the Food and Grocery Council, which is assisting this, or trying to assist the struggle against obesity. But the food industry is not the only player in this game, and we have got a track record, and again I can point you to that, of where we've partnered with other organisations at the federal government level, but also at the state and territory government level, assisting or providing input into this issue.
Your council has said that you want to be part of the solution. You've just mentioned that then. But also the personal responsibility argument. Can you understand why some people might be cynical about your willingness to become part of the solution if you don't really accept that you're a part of the problem in the first place?
Well, I've been working for the food industry for an awful long time. We put 19 billion meals on the plates of Australians every year. The food supply is safe by any reasonable assessment of that word. It's affordable. It's nutritious. We are indeed, though, in a little bit of a nutritional paradox. I mean, it is certainly true that never before in Australia, and perhaps in the whole of human history, has such a wide choice of foods been available from which people can construct healthy diets. Not only that, there's more information about those foods than ever before in terms of nutrient labelling in all of its guises. And not only that, there's a whole raft of nutritional science behind it. But it is still a struggle to get people to eat according to the dietary guidelines and to eat healthy diets. Now, whether it's the food supply itself, or whether it's how we communicate about food, or whether there are some other problems involved with society, and we've heard the term obesogenic society formed, and indeed there is evidence that people are more sedentary than they ever have been before. The food industry certainly recognises that it has a responsibility, and if you look at the history of the food industry, it is one where they have responded to nutritional science. I mean, it's 50 years ago now that polyunsaturated margarines first came onto the market in response to advances in nutritional science. We have a plethora of low energy, low salt, low sugar, low saturated fat food products. In the 80s, we started fortifying breakfast cereals. In the 90s, we started fractionating milk, so there was a whole range of different types of milk you could eat. And in the 90s, we started taking trans fats out of products. So there is no evidence that the food industry is not responsive to advances in nutritional science, and it has been responding to the challenges of obesity. However, we do not believe that it is solely the food supply in its own, solely the food supply that is the cause of the problem. But of course, food is part of the problem in the sense that obesity is caused fundamentally by people eating too much and perhaps, certainly an unbalanced diet in the classic nutritional sense of the word. So we reflect that, but ultimately we also think, and I think most reasonable people think this, that people ultimately are responsible for what they eat, and we cannot take away from that, and we cannot really regulate for it, at least not effectively.
Well, in 2017 we have a range of new Fanta flavours: sour tingle, orange jelly fizz and raspberry jelly fizz. I mean, these are targeting children. So on the one hand, you're donating money to look into childhood obesity. On the other hand, encouraging products directly marketed towards children. Nobody could argue that those products are a part of a healthy diet, I don't think.
Well, actually, I could argue that, because there is a fundamental nutritional maxim that there are no healthy foods and no unhealthy foods. If you really want the nutritional science, the science is that there are healthy diets and unhealthy diets. All foods can be incorporated into a healthy diet, and the contrary to that is all foods can be incorporated into an unhealthy diet. Notwithstanding that, the food industry has done a lot in terms of marketing to children in the last 8 or 9 years. In 2001, in January 2001, the food industry, in response to the Australian Communication and Media Authority's examination of children's television standards, the food industry responded by introducing the Responsible Children's Marketing Initiative. Now, again, I recognise that this is one of the issues that has been covered in the popular press, and they would have us believe that there are no restrictions on the way food products are marketed to children. But in fact, the opposite of that is true. We have self-imposed restrictions and guidance to food companies about how foods can be marketed. So the incidence of advertisements and the promotion of products of different types has gone down enormously in response to that. So I think the food industry is responding responsibly, and the vast majority of products are promoted responsibly and labelled responsibly in the marketplace.
We're going to move on to physical activity. There seems to be plenty of support for increasing physical activity as parts of our effort to tackle obesity, and we may come back to food at the end as well. The benefits of physical activity extend much further than obesity reduction, but with statistics showing that under half of Australian adults meet the national recommendations on physical activity, and an increasing number of children and adults spending extended times being sedentary, there can be little question that increasing population levels of activity is a worthy and important focus. Former Olympian and Commonwealth Games gold medalist Jane Fleming, OAM, joins us today. Jane, it's a great privilege to have you here today. Jane is also the Director for the Live Life Get Active program and will be able to provide us with some important insights. I understand the program you run, Jane, Live Life Get Active, is offered at no cost. With some gym memberships ranging in the $100 per week mark, do you think the cost of participating in physical activity is what prevents some people? And is the no pain, no gain mentality another barrier to participation?
So when we set up our business 3.5 years ago, our overarching product development was around removing all the barriers to having a healthier life. And our research showed that cost absolutely is one. Convenience was another. Intimidation is another, and we joke that really unless you are under the age of 35 and look good in Lycra, then no one goes to a gym. And the statistics on gym membership across our population are horrific. So we have, 25 million people in Australia, and there's 1.8 million paying members of gyms. Around 30% of the people that buy a gym membership never, ever go. So our business, we offer free fitness classes to the community Monday to Friday in school terms, and they range from a cross-training, a boxing and a yoga, and every one of our classes can be done by intermediate, beginner and advanced levels of fitness. So the non-intimidating thing around having no whistles, no yelling, no music is absolutely part of what attracts people to our business. The cost, absolutely, the fact it's free is very important, but not necessarily because it brings people to our camps, but it allows them to invite a friend to come along as well. And then we get that social connection, which becomes the stickiness of keeping people repeatedly attending our camps. So there are a number of things that we've found through the development of our product that it allows us to attract what we then call gym rejectors, or in fact sports atheists. Our members, not in a million years would they ever have the body confidence, let alone the personal confidence to join a gym or to join a sports club. We may be the avenue for them to do that further down the track. And we have people that have had very serious medical conditions that come and join us. Genesis Care, the radiation and oncology company, partners some of our camps, and they see our camps as being able to assist with maximising their patient outcomes, but also as a means for those patients to come back and reconnect with the community after going through some traumatic events as well. So, we have an 86-year-old member, we have 18-year-old members and everything in between. And most of our camps are in the sort of, obese belt, if you could say, out of metropolitan regions. And they have proven to date to be very successful, and we have really sort of very measurable ways of showing a return on investment as well.
Your program brings together big business and local councils to offer the classes, I believe, and also some simple nutrition advice. Do you think we should be looking for more opportunities to engage with big business to support these initiatives?
Look, I can tell you it's been a hard slog, and we have some amazing funding partners now. We deal with a lot of property developers, and they develop those new estates, either high density inner city or sprawled new estates on the outer metropolitan regions. they come to us not necessarily around the physical health benefits of what we offer, but we offer the ability to build community. And we see and hear from our members that having a sense of belonging is very important, and it can, in many respects, that sense of isolation can be a precursor to so many other medical issues, as you would know. So they've come to us. What we ask them to pay for a year-long program of 200 days a year is less than what they would pay for a one-day launch. So we deal with Stocklands and Frasers and Mirvac and Lend-Lease, and I have to say some of those organisations have incredible ethos towards building communities and building happy, healthy communities. I can think, in particular, there's one in Sydney, Frasers built a development in a place called Campsie, which is more lower socio-demographic than the other extreme. And instead of them putting hedging around their green space, which is beautiful and it has a fantastic open playground, they've planted rosemary bushes all the way around the outside and lime trees and sage plants and the like, so that their residents can go down and pick fresh herbs. So there's lots of thought that goes into their construction. I think the obvious choice when you think to go to big business for us, they haven't really come to the party, and we're still looking. We have gone to federal government and state government on numerous occasions and just found that it was like hitting our head against a brick wall. And we have very evidence-based results, and Amanda King, my business partner, and I have come from quite commercial backgrounds, and it was just taking them too long to ever get anywhere. So we just went out and found organisations that were willing to try and help us. And we hopefully will continue to grow, and I think we'll hopefully by the end of the year have over 200 locations across Australia. Now we target the demographics that we look at by amending the time of day of our camps. If we run a class at 9:30 in the morning, we generally target young mums and people over the age of 55, and then in response to that time we get this fantastic cross-generational interaction, which has been delightful to witness. If we're in a commuter belt, we put classes on at 6:15, 6:30 in the morning. If we're in a CBD, they generally tend to be lunchtimes.
Do you have as big an uptake from men as from women?
What we found, we don't at the moment, because most of our classes are around 9:30 in the morning, and also because of the locations of where our funding partners, because they have a say in where our camps are located. But the other thing that we have found with men, which has been very interesting, is often men will register, but they take a while to then come along. So they kind of tend to have a little bit more of a look. The thing that we do find, our average member is a 37-year-old mother, is that once the female gets involved, of course they're the driving influencer within a household, is then the whole household's behaviour changes over time, which has been fantastic for us. And our nutritional advice is very adaptable to cultural variations in terms of the way people eat, and also something that can apply to the entire family, and it's not prescriptive. So we found that our members have said they use it more as guidelines rather than something that has to have a start and a finish and specific groceries bought and the like. So it makes it easier for them to implement that across their family.
More generally, do you see a bigger role for workplaces in physical activity of their employees?
Absolutely, and we see that now. I tell you the one thing that we do notice with big business, the use of the word sustainability is enormous. And we have now been put into, for example, with Stockland's annual general report, they put us into their sustainability reporting with, the amount of kilograms their camps have lost and the amount of centimetres from their waist circumference and the likes. And so that is really, from our perspective in big corporate world, we see that as being the catchphrase and the really on-trend sector of their businesses. The other thing around that, we tend to find them more interested in helping the communities that they're working in rather than looking internally at their staff at the moment, and that's something that we're building up to look at the moment. We do have a couple of government departments that partner fund camps in New South Wales for their staff. One of them started out in Liverpool for the Family and Community Services, and that had fantastic take-up by their staff. They had 600 people in an office block there. The other one that we've just done, AMP Capital, own 4 commercial buildings in Sydney CBD, and we offer a priority booking to their tenants. They get 24 hours before our booking system opens for their tenants to come along. So what we're now trying to encourage those landlords of those big, huge companies is to now start to offer this instead of a gym that costs lots of money, that has insurance and risk elements added to it and that don't get uptake within an organisation, within a building, within a structure. We're trying to ask them if they will fund a camp and then encourage people to get outside and go. Professional services have been a nightmare. Professional service organisations, law firms, the big four accounting firms, not one of them have taken it up. They talk the talk, but they definitely don't walk the walk.
So Jane, your program's also available online. Are you concerned that the legitimate advice that you provide online to your participants is overshadowed by celebrities and media personalities and others who perhaps are less qualified to provide the advice?
Look, I think we have both an ability to communicate to our members both online and in person through our trainers and message through our trainers. And I don't think we'll ever get away from that celebrity thing if you look at the whole ridiculous Kardashian, Paris Hilton, that whole thing nowadays. But we just hope that what we do is we're affecting them at the cold face and we have a real interaction with them on a daily basis. One of the things that we were talking amongst us is we have the ability to communicate to these people every day through our trainers. And we have a philosophy that as long as the messaging is in keeping with our philosophy, which is building a fitter, healthier and happier Australia, that we are more than willing to do that. For example, Campbelltown Council partner fund a camp in a place called Macquarie Fields, which is very low socio-demographic. And we said to them, we are happy to say to our members, don't forget, the local fun run registration opens this week, or the pool hours are extending, but we're not going to tell them that hard rubbish collection is next week. So we don't want to waste those opportunities. So we have the ability to do that. We would love to start building a closer relationship with our local GPs, and we have commenced a program with 3 practices through Genesis Care and another general practice in Blacktown, where we've produced a thing called a positive prescription, which it's a prescription pad that we're giving to the GPs and to the practice, and it has the addresses of our local classes on them. The doctor, as he's writing out the pharmaceutical prescription, tears off one of these and says, you need to exercise, take a friend, they're free. Our trainers are contracted from the local community, so they have their own sense of that community as well. They all are fully qualified, have current first aid, current CPR and the likes, and they go along and they meet people from within their community that are also travelling along the same path. So we're hoping to start implementing that, and every time we launch a camp now, we will end up finding some resources somewhere where we will have someone then contact all the GPs in the area and say, here's either a soft copy or hard copies of these prescription pads, so that you can start doing that as well. And, so we've got lots of other initiatives that we're looking at as our business develops more and more.
Thank you. I'm going to move on now to, a community focus on this. And Dr. Stephen Allender is a Professor of Public Health and Founding Director of the Global Obesity Centre at Deakin University, a World Health Organisation collaborating centre for obesity prevention. Steve is involved in ongoing research into many facets of obesity, including potential contributors. Thank you, Steve, for joining us today.
Thank you.
We know obesity levels are clearly linked with lower levels of education, income, certain professions, increasing remoteness of residents, and a range of other factors. In media reports, you've linked the importance of population-wide approaches to obesity prevention due to the increasing likelihood of obesity among people from lower socioeconomic backgrounds. Can we engage in a meaningful effort to address obesity without seeking to also address the broader social determinants of health?
Thank you for the question and the opportunity to speak. I think the other speakers have made that case beautifully before the question was asked. If you look at our efforts to prevent obesity in the last 40 years since we became aware we had a serious problem, they've been largely a spectacular failure. And that's primarily because the logic model we've been using is a basic one of energy in versus energy out. And so what we've done is we've focused on one aspect of energy in and forgotten about the rest. So we see a study that says kids who drink soft drink are more likely to be overweight and obese. Let's focus on getting them to drink more water and forget everything else. And one of the communities we work in, as an example, this happened, and the drinking water in that town was very poor. You couldn't drink the water. So people gave the kids a drink bottle and said, please drink more water. And then a parent would be going home that night and stop in the supermarket and say, right, well, they won't drink the tap water, but we must get them something for the table. And in that supermarket, a litre of water was $2.80 and the litre of Coke is 75 cents. And that's the sort of misunderstanding that we've made over and over again, that an individual level focus fails. The work we've done in the last 15 years in Western Victoria, we have 4 successful trials in the prevention of childhood obesity. One of those in a place called Colac worked better in the low SES families than the high SES families, and the magic, the dose, the thing on the spoon, was to provide those communities with the opportunity to design the changes in their community based on their own context. So the things that were pushing in the wrong direction in that community were changed from that community's perspective. So when we do that work, we see a lot of different social determinants that range from 2 parents working, low household income, access to drugs, and so on and so on. And in the past, and under a randomised controlled model, we would pick one behaviour and target it and ignore everything else. The innovation in the science, if we look at the Cochrane reviews and we see the evidence about what is working, and this problem is preventable, and we forget that, this problem is preventable, the efforts that work are community-led, are embedded in community action, and take multiple points of intervention right across society, from changes, the sorts of changes Jane were talking about, access and availability to opportunities, all the way through to policy change. So short answer is no, I don't think we can.
Okay, so we've already discussed the proposal for a sugar tax. What does the evidence tell us about the best population level measures to address obesity? I know you've touched on it, and maybe specifically in Colac, how did things change?
Well, and I think we've got to stop thinking about an either or. So one of the conversations before was there are some 80 policy recommendations, and which one do we pick? The answer is all of them. I mean, I think our effort needs to match the size of the crisis. If a virus arrived into Tullamarine tomorrow morning and it spread within a day to affect 2/3 of the adult population, and it reduced life expectancy by 20 years, and it cost the economy $60 billion, what would we do? We would be up in arms and we would shut the border, and yet that's happening year on year on year on year, and we're primarily ignoring it because the timescale of that happening is different to a typical sort of pathology. So the sugar tax is critical, and I would disagree. There's no evidence for it being effective in terms of reducing consumption. I think what we're learning in Mexico is that there is evidence that it reduces consumption, and there is evidence that it reduces consumption in low socioeconomic groups. We've also seen that if we give leadership within communities the chance to see this problem, they are willing to respond. So in some of the communities we've worked in, we've created a monitoring system where we measure upwards of 90% of the kids. The usual way we do that, we get at best 60%, and we would say, well, we think the prevalence amongst kids overweight and obese is 25 to 30%, and we think it's plateaued. And actually what's happened is the participation rate is steadily going down. When you get 92% of kids, prevalence is somewhere between 38 and 54%. There is no plateau, this crisis is increasing. We gave the leaders in that community the ability to see that. And one of the things that happened is the 13 health services involved in that region banned sugar-sweetened beverages basically overnight. They changed the menus in those hospitals 80% green food, and they introduced unanimously a KPI for each health service that said, we will do everything we can to halt the year-on-year rise in obesity within 5 years. And I'll put that a different way. The health service CEOs I work with, all of them will say, we've got to move away from treatment. We're at the bottom of the cliff, picking up the pieces once the problem's installed. We have to have a role in doing something about prevention. When you talk with communities and you offer the opportunity to see the problem, people are angry and ready to respond. And what we have to do is give them the tools to do that. And there are plenty of studies, and you can look in the BMJ, George Davies-Smith in particular is very good at this, but when he does observational studies at a national level of populations where for various political reasons there's been a restriction in calorie availability, you see a reduction in obesity, you see within 2 years improvements in heart disease, diabetes and mortality rates as well. So it's fundamentally possible. It's a matter of people being angry enough and the political will being there to make the change.
It seems to me that that will isn't there at the moment. So who is accountable for this, and who should we hold accountable for this?
I think the lessons we've learned over the last 20 years in trying to embed this work in policy is that the election cycle is so short, and the conversations you've had at this meeting are largely sound bites. It's very difficult to get federal movement, would be my argument. All politics are local, and local community leaders and local community politicians are very, very keen to see their communities improve. So we now know that a child who's overweight or obese has significant reductions in their employment prospects, educational prospects, worse mental health than they would if they're a healthy weight. Our studies in the ACT, within 2 years we get a 5% reduction in obesity and a relative reduction in mental illness amongst kids that goes along with that intervention. At a local level, a principal doesn't care at all about whether or not the weight of their kids affects the bottom line of the budget in 60 years' time. Irrelevant. But if we say, if you can improve the health of your kids here, it will improve their educational prospects and their behaviour, fundamental leverage point for that particular point in time. You ask me who's responsible, I would say everybody. If 70% of the adult population is overweight and obese, and the environment is what's doing it to us, and we're not angry about it, then that's our problem. I think it's everybody's responsibility, and particularly rooms like this. This is a room that understands this problem and the implications of it better than just about anyone else. You know, the education that sits in this room about disease, burden of disease, health and illness, possibilities for change, is probably unparalleled. It's rooms like this that have to get angry to get communities mobilised so that the votes change. There's votes in it, it'll shift.
Steve, do you have an opinion about individual practitioners, community practitioners and their role?
I think there's multiple roles. An individual practitioner is also a member of the community. They're also a parent. This is somebody in a community who can understand what an odds ratio is, who can understand if a new study comes out that says, actually, this is a really fabulous way to do prevention. In that community, there's very few people who can translate that quickly. And there's also a huge amount of respect and a very established position for GPs in communities. The work we do in most communities, we start with the health service and we spread far beyond that. But the person who's able to best engage the retail sector is the local GP, for example. And the work that we do with our communities is to ask, can we capture an understanding of how this system works for your community and how do you fit into a response? And so I would say everybody has a role.
So I'm going to move on to one of those GPs now. GPs are said to be the gatekeepers of the health system, but more recently concerns have been raised about how GPs engage with their patients on obesity. An article in The Conversation last year argued that health professionals lack confidence in knowing how to address obesity in their patients, and that they also report minimal, if any, training on obesity, which impairs their ability to engage in effective conversations with patients. Insufficient time in the clinical setting was also found to be a barrier to effective responses. Dr. Tony Bartoni is our own Vice President of Federal AMA and a GP, and was involved in the update of the AMA's position statement on obesity. Tony, thank you for making yourself available for the panel. Can I ask you about that criticism that's been levelled at GPs for their role in tackling obesity? Do you think general practice is geared towards treating and managing those patients?
It would probably come as no surprise to you, Brad, that I do believe that GPs are uniquely placed and uniquely positioned to treat and to manage and initiate that conversation in obesity management. If we look at some of the research in particular from International Journal of Obesity just recently, it showed that when GPs and primary care providers provide information and guidance in managing and initiating a conversation with their patients, that they did then engage in appropriate weight loss behaviour. Monash research also showed that the community and patients really regard the information that they receive from their GPs. So we are uniquely placed. The training we get in our undergraduate and then in our early postgraduate training underpins that behavioural impacts and behavioural relationship involved in the complex issue that is weight management. It's not just a case of what goes in and what goes out. It is much more complex than that. Can we do more training? Can we do more upskilling? Well, that it really comes down to the availability and the appropriateness and facilitation of courses and training opportunities. But what we really do need to then is turn that flip side around. So we know that GPs are uniquely placed both because of their relationship with their patients, both because of their opportunity engaging with patients. So we know that the average Australian visits a GP at least 3 to 4 times a year. We know that more than 80 to 90% of patients see their GP at least once a year. So that positioning of that opportunity to have that conversation is clearly paramount. But then if we look at the setting of general practice currently and the way it's resourced and the time, which has already been raised this morning, patients come in with a list of problems, and then and there's usually a multifactorial or chronic disease that's in there that needs to be managed, and then the central role of weight management is crucial to all of them, and allocating time in that complex environment in the appropriate setting, which is usually a single appointment that the patient's not made a double, or if you look at the issues that even the way the item number structure of the way we're remunerated does not support that really long involved and behavioural modification that needs to happen in a lot of the consultation around that, where you can see how general practice is further and further being put at significant impost and significant burden to have that appropriate intervention. And then you throw in factors like the fragmentation of care that's occurring on now, so that lack of opportunistic intervention and conversation to engage with our patients. These are all further barriers to really having that. But as I say, the average patient who has a longitudinal relationship with their GP is obviously primed and ready to initiate and begin that conversation in weight management.
Tony, do you think that the referral pathways are clear, and do you think there's any role for the primary health networks in this space?
PHNs, primary health networks, are in their infancy, and there are varying degrees of maturity around the country. But if we look at what they're tasked to do in terms of supporting general practice, they are uniquely placed to assist us in that. We know that the solution, part of the solution, is a multifactorial approach, and it requires usually a number of members of an allied health team under the leadership of a GP. That's where PHNs can support and assist with resourcing and novel solutions, novel innovations. We know that some GPs partner with dietitians and have dietary cooking classes and discussions there. I'm a firm believer that the GP needs to be a leader in their community, and that obviously needs funding and support, and that's a unique place for the PHN to become involved and partner with their GPs in their district. Because if the GP is part of that community and messaging appropriately, it can also, when supported with all the other issues that we know, can begin that wider appeal. It's about the messaging and the information, and clearly PHNs are uniquely placed in that area.
Recent research from New South Wales Health found that over 70% of parents with an overweight child believed their child was a healthy weight. With overweight and obesity increasingly becoming the norm, are your patients happy to engage in conversations about obesity and how it may be affecting their health?
Look, that's a question that's often raised, or a position that's often raised, and I really get disappointed to hear that. Of course, in our longitudinal relationship with our patients, we are in that special position, that special place to begin and have that conversation. Now, my patients know what they can expect, They know, even, you know, because of the messaging that's out in the waiting room, the messaging that's in the pamphlets, the messaging that in information about the practice, they know what they can expect when they come in. And, you know, the tape measures on the desk, they see the scales there, and they know that it's an important part of the conversation. They know that if they have the, you know, you need to have that ability to raise that information and raise that concern with them. Of course, new patients, it's a different dynamic, and it might be a bit more tender and a much more feel your way approach with the personality of the patient concerned. But at the end of the day, they know that we have their best interests at heart, and it's about the way we communicate that information and really share that we're interested in their outcomes and we're interested in their health and long-term well-being, and we couch it in that position. Some patients are resistant, and that's where you need to look at all the other issues around behavioural modification and the appropriate psychological tools to try and get that motivation, that buy-in. But it comes to, as our position statement says, it's about a multifactorial approach. It's about the opportunity, and we've heard our other speakers today reference the physical places and spaces to engage in activity. It's about nutrition information. It's about the wider community information and public health messaging and resourcing of those campaigns. It's about food labelling. It's about all those steps and more. But at the end of the day, they know that they can trust the information they get from their GP, and they appreciate that when we do raise those issues, we're raising it with their best long-term interests in mind.
Tony, do you see a role for commercial weight loss programs, and do you refer your patients to them?
And this is really, this is where the lack of clinical, the detailed clinical guidelines that are sort of not there ready to assist both in terms of the clear messaging and also the wider community and media misinformation. That's where the major role we have in trying to advocate and change that information. Commercial weight loss products, the majority of them are just a waste of money. We know that, and the yo-yo diet and the yo-yo phenomena is quite well established. What we do need to encourage is an understanding with our patients of the dynamics and the issues that underpin the weight management, and obviously it's about really lifestyle modification and all the other things that go in to appropriately understanding. The problem is, of course, when you go to some establishments, you're bombarded with a whole range of commercial reasons to join up or buy this or use that, and that really does send a mixed messaging, and that's where the wider community messaging needs to be improved, and the public health messaging needs to be improved. Celebrity endorsements. The celebrity chefs in particular have a real responsibility to speak of what their knitting allows them to speak on, and not on anything else.
Thank you. There's a certain paradox when it comes to obesity. Sometimes there seems to be a sense of hopelessness, that at a certain point the idea of losing weight is just too hard. However, we also see material released from organisations like the Australian Institute of Health and Welfare that shows that modest weight reductions, say 3 kilograms, can improve health at an individual level and also make a significant contribution in reducing costs to the health system. Nevertheless, it's true that the proportion of adults who are deemed to be severely obese, a BMI of between 35 and 39.9, is increasing. In fact, it's been more than doubled in the decade from 1995. This is a concerning development, and patients may require a more drastic intervention. We're now joined by Dr. Ahmed Ali, President of the Obesity Surgery Society of Australia and New Zealand, and a bariatric surgeon here in Melbourne. Dr. Ali, thank you for coming today.
Thank you.
Presumably you provide surgical interventions to people whose health is compromised because of their weight. What would you say are the main causes or contributors to weight gain?
It's easy to understand where the conventional thought lays causation and contribution at the personal responsibility level. it's easy to understand that paradigm of thought. It's what we've all been brought up on. But the evidence is very clear. Obesity is not a lifestyle choice. People don't choose to be overweight. They have personal responsibility in their actions, but they do not choose a deliberate strategy to be overweight and obese. So what's really going on? Is it simply a matter of lack of willpower or discipline? The fact that obesity has increased alarmingly, and we have this seemingly unable to help patients easily lose weight and keep it off, despite them being disciplined in almost every other facet of their life. We all know people that struggle with their weight and yet are personally responsible, dedicated, apply discipline, are productive, and yet the one thing they can't control in their life seems to be their weight. And it's pointing to what we now know from our science and our physiological research, and that is that obesity is a biological disease. It is determined by genetic predisposition, and that genetic predisposition finds its expression in the obesogenic environment. The obesogenic environment is of modernity, and hence the rapid expression of this genetic predisposition that has always been there, but not had the environment in which to express itself. It's these two factors together that have led to the obesity epidemic. The genetic predisposition is essentially that of appetite control. Biologically, this genetics determines our set point for weight and our appetite regulation to achieve that set point. And hence you get the yo-yo dieting effect. It's been shown unequivocally that when people diet and lose weight, the physiological shifts within the body increase appetite, ultimately driving that person to meet that appetite need and re-establish their weight until they get back to that set point, or potentially add some more. Appetite is an ancient survival mechanism. It's in the oldest part of the brain. It sits right alongside heart control, respiratory control. So the analogy I put to people often, if weight is simply a matter of discipline, if weight is simply a matter of willpower, if weight is simply a matter of choice, then hold your breath and see how long your willpower overpowers the innate drive for survival.
So in light of that, should we make more of an effort to recognise that for an increasing number of people, intensive or surgical intervention is the best approach?
I think we should, and clearly I'm speaking potentially from a biased point of view, so I'm going to answer it actually in a non-surgical way, and I'm going to reference Alanda's description of the virus and how we would all be up in arms. And yet there's a subtle difference here. The difference is that the virus is an exogenous agent of which we have little control. In other words, we do not blame the person that is suffering the virus. But because we confuse personal responsibility with choice and lifestyle choice and misunderstand the biology of obesity, we lay the blame at the feet of the patient. And that's the paradigm shift we need to move away from. We need to understand that obesity is a disease. It is not a lifestyle choice. There is personal responsibility in action, but the drive for weight is beyond simple discipline and choice. And our problem with implementing strong, aggressive preventative measures, or indeed interventions like surgery, is because we believe it is about choice and not about biology. We need to shift that paradigm of thinking, and once you do that, these preventative strategies, the will for these preventative strategies, the will for appropriate treatment and intervention, including surgery, changes.
Can I ask you to comment on the availability of public bariatric surgery in Australia?
This is an area of great concern to us in the profession of bariatric surgery, and as the president of the Obesity Surgery Society of Australia and New Zealand, it is a major area of work for us at the moment. About 90% of all bariatric surgery is performed in the private sector. That means only 10% is performed in the public sector, and this is related not because of a lack of demand, but because of a lack of provision. And that's a situation that needs to change. We pride ourselves on an equitable health system that provides access regardless of circumstance, and this is one area of service that is simply not keeping up. The provision isn't there. And so we held a National Public Bariatric Surgery Summit recently in Sydney to try and understand the impediments to the provision of public bariatric surgery, and we're now working towards a national framework to hopefully influence policymakers so that we can increase the access to public bariatric surgery. This is particularly important when you consider, as has been mentioned many times now, that obesity is more prevalent in the lower socioeconomic classes, and potentially we're limiting access to those that need it most.
Is the age of your patients dropping, and do you think that surgical intervention is going to be seen more in children in the future?
Yeah, thanks for that question. I think we have to understand the place and role of surgery in the overall treatment context of obesity. Surgery is clearly the most effective single intervention in the treatment of obesity and its related comorbid disease. And I think the audience understands very well the associated comorbid disease. In fact, there are very, very few publications that can demonstrate sustained meaningful weight loss and reversal of comorbidity in the obese population with any treatment other than surgery. And that's the great fight that we have, that's the great frustration that we have. And this potentially applies to children as well, though the evidence currently is still limited. And the effect of bariatric surgery in children is still understudied. And so I would not advocate its broad use, certainly not as a first step intervention. It can be part of a suite of programmed treatment where exceptionally it may be used. We are seeing greater obesity rates in children. We are not reflecting that in our surgical intervention in the under 18 age group. I think it is a special group that requires specialist treatment and specialist centres, and particularly in that group, a graded intervention strategy. Having said that, I think that's appropriate for bariatric surgery as a whole. We have traditionally, I guess, thought about surgery and medical therapy and lifestyle intervention as all these distinct measures, distinct treatments that somehow you either have one or the other and one is put up against the other. And it's simply not true. Obesity is a multifactorial problem. It is a chronic disease, and we don't expect to treat any chronic disease with a single intervention or a single agent. Why is obesity any different? Surgery simply is part of the paradigm of treatment of this chronic disease.
Ahmed, George Christensen, the LNP MP, recently travelled to Malaysia for weight loss surgery. I think we should acknowledge that he took some responsibility for getting some treatment, but was there any benefit in him having that treatment overseas and not here?
Well, I'm not privy to Senator Christensen's reasons and decision process in making that, but certainly from a clinical point of view or a safety point of view, I can't see any benefit in having surgery overseas. Australia has extremely high standards of surgical training and performance in all areas, but also in bariatric surgery. We have a national registry now that is collecting around 70% of all bariatric surgery that's being performed, and we expect by the end of next year we'll be collecting 100% of that data. And that is demonstrating, as has many studies, that bariatric surgery can be delivered safely and is being delivered safely in Australia. The major complication rate for primary bariatric surgery procedures in the registry is running at around 2%. The mortality is less than 0.02%. So safety and standards in Australia are extremely high. Outcomes are also extremely high, without elaborating on that data. My main concern about anyone having surgery overseas is that surgery should not and must not be seen as a single event, and that's the end of the story. Surgery is simply a step in the pathway of the management of that patient's chronic disease. It must and should be delivered in a multidisciplinary environment with appropriate dietetic, psychological, exercise support, physician support, ongoing surgical care. Typically, we deliver bariatric surgery in those sort of teams. It is a lifetime contract, much as the GP has with their patient. So to have surgery isolated outside of a team concerns me, and if anything, is less safe.
In the short amount of time we've got left, I'm going to ask each panellist to have a little think about what their take-home message will be from today's session. And while they're having that thought, Jane Fleming, we are asking young women particularly, but young people, to not be ashamed of body image and to not focus too much on body image at the same time that we're trying to get the population to have a healthy weight. How do we get those two messages across safely, do you think?
I had an interesting experience at a dinner party about 18 months ago when I was having a conversation with a mother of late teenage girls, and she was overweight, and she was saying there's no way we can talk to our girls about food because we don't want them to end up with an eating disorder. And then I quoted to her the statistics of eating disorder versus obesity, and then the other health effects that obesity has, but it still seemed to get shot down and not listened to. And I think it is a very scary conundrum that we have, in that is the way that most mothers think about talking to their daughters in particular around body image. Your reference to the fact of what is perceived as normal is something else that I think that we as a cohort need to start to address. It is not normal to carry, an extra 10, 15, 20 kilograms, and the subsequent health consequences to that down the track for a young person of any gender is awful. And so I truly believe, I used the word fat the other day in something that was picked up on in the media, and I stand by it. And I'm sorry, that is what it is. We can't sugarcoat that, excuse the expression. And it is what it is. You are overweight, and that will contribute to economic issues for the whole of the community, that will contribute to your health issues, to your quality of life, to your mental health, and everything else that we know that comes with it. And I think it's a really difficult situation. We even get the likes of a Kim Kardashian who carries an enormous amount of weight, and she would be considered on all of our BMI measurements or any other measurement, she would be considered overweight, and yet she is revered. So I think there are difficulties with how we address all of that. The one thing that I would like to point out that we seem to find in terms of the yo-yoing and the other things that come with that is the expectation for those people that we deal with, and the celebrity thing is not to have instant results, and that we talk around health rather than around weight. And our nutritional advice to all of our members, if you are aiming to lose weight, then we would like you only to try and lose 1 kilogram a month. And we need to make small behavioural changes that are sustainable. And I think in terms of addressing teenagers, children, things that are easy to include in your everyday life, that's my call on walking to school, on stand-up desks, on moving drop zones, on removing travellators from airports, on a whole series of other initiatives that are actually really action-driven. And I think that's one thing that the group of doctors that you, and influencers, because you have very large influence on the way people think, it's around, let's try and get people just to do things that are easily incorporated in their life to start with, that are of a sustainable nature. And I really get very concerned around 12-week body transformation programs and the likes, because all we do is further cause, I think mental issues as well around weight, as opposed to let's look at what we can do that's on a sustainable nature. And with girls in particular, I think we need to start talking to them about health. You know, it's not about how you look, and it's not necessarily about body image, but let's try and look at that in terms of health rather than weight.
Thank you. Professor Stephen Duckett, any final messages for the audience?
I think it's been a great panel, but my view is there's no single solution to the problem of obesity, but that one of the parts of the solution is a sugar tax, and we should pursue that as much as we can, and I thank the AMA for having it in their policy as well.
Thank you. Jeff?
Well, I think my message would be that there is a partnership approach. The Food and Grocery Council has been partnering at the Commonwealth Government level on many projects, the Health Star Rating, for example, and the Healthy Food Partnership, and the sort of initiatives that Jane's been talking about. I mean, that is actually encouraging people to take personal responsibility, but at the same time, the food industry sees that it has a role through the activities of providing choice in the marketplace and appropriate labelling and appropriate promotion of its products. What I would hope is that we would get away from some of the polarising debate, and we have had polarising debates in the past, and you know, quite frankly, the sugar tax and the focus on sugar is neither supportable from an economic point of view, and it's certainly not supportable from a nutritional science point of view. So I'd encourage that and engage more widely about how we can just encourage people to eat more healthily, which basically means eating less and eating according to the dietary guidelines.
Steve Allender?
I agree with everything that's been said. I think we need a strategic systemic response where every sector of the community asks and responds to the question, what's your role in turning this problem around?
Tony Bartoni?
I think there's been a very informative and very constructive panel discussion this morning, and it clearly emphasises that one, it's a multifactorial approach is needed, but there does need to be some coordination, and that's the role for the federal government. It does need to show leadership and initiative. There are many, many things that can be done. Our position statement outlines a vast range of measures that can be begun, but the importance in the discussion of prevention in an advocacy space and the understanding that there is an economic dividend to prevention which will pay back in spades in the years ahead needs to be understood by all the people, regulatory and non-regulatory people that are involved in this space. The conversation is an ongoing one. We do need to get more and more information and more statistics around the community and the scale of the problem to ensure that we've the right messaging, but public health messaging is deficient. It needs to be significantly bolstered, and we all have a role in this to solve that, a very crucial problem for our community.
Ahmed Ali, I think you probably did summarise beautifully, but anything final words?
Look, I think I agree and support the importance of population health strategies when we consider this as a public health issue. I think what needs to be increasingly understood is that in terms of helping an individual, surgery has an underutilised place currently. It is an individual level intervention, it's not a population level intervention, but it is dramatic in its effect on quality of life and improvement of health. And if any new thought I'd like to leave you with, it's this, that we've often thought about surgery. In fact, Jane mentioned the fact that we're focusing on weight, but that's not really the outcome that we're considering. The paradigm shift in thought I'd like you all to consider is that obesity is contributing to virtually all of the chronic diseases that we are managing. And surgery really simply fits into the paradigm of the management of those chronic diseases, much as the International Diabetes Federation has now incorporated surgery as part of its paradigm in the treatment of diabetes. I think that shift is going to happen in many of the chronic diseases. So rather than simply thinking of surgery as an obesity intervention, it is part of the suite of management of these chronic diseases. And in fact, without using it, we're not offering everything available to the patients that carry those diseases.
Thank you. I think...
There's a gentleman who wants to ask a question.
No, I think we've gone over time. So I'd just like to acknowledge the incredible work that Josie Hill and the public health team at AMA have done to organise this session. We've been privileged to have an absolute wealth of knowledge in the room to talk to us today. I've enjoyed it very much. I would like everybody to thank our panellists very much for today's session. So will we do that up here? Okay. So we just have a gift for each of you. So I'll just hand these out. Yep, sure. So thank you. Thank you. Jane, thank you very much. I'll walk up with him. I don't think it is. Excuse me, I'll just hand these out. Thank you very much. No, that's for you. Thank you very much, and I think a photo opportunity is required, so I'll just duck up here. Sorry. Thank you all very much.
All right, now, can you get
Sorry,
off?
I've got my stuff up here.
You're good, Brad. Perfect.
Thank you.
Well, thank you, Brad, and thank you to your panel. That was a remarkable session. Okay, we're going to break for morning tea. Can I just... two housekeeping arrangements. If you wish to speak in the soapbox session, please register your name and topic with Lauren before we come back from after morning tea. And the buses start leaving from 11:30 every half hour until 6 o'clock tonight, and they do leave from the driveway this time because they're little buses. See you back here at 11. Thank you.